Hello, welcome to today's first ever Vasculitis Women's Conference. I'm Joyce Coleman, and I'm the Executive Director of the Vasculitis Foundation. Thank you for joining us today. It is wonderful to have so many participants ready to connect and learn from our incredible speakers and from each other. Our goal for today is to develop a greater understanding of how vasculitis impacts women in all aspects of life and to build upon the collective strength of our community through education and connection with other patients living with vasculitis. This conference was recorded live on June 12, 2021. We have edited the 5 sessions into individual webinars and encourage you to watch all of them as you have time. Each session is unique and all of the speakers share important knowledge and expertise. My co-host for today's conference is Kaylin Young, the Director of Development and Communications with the Vasculitis Foundation. Kaylin has her master's degree in social justice and human rights, specializing in qualitative research methodologies. She served as the Director of Research Affairs for the Vasculitis Patient-Powered Research Network, our VPPRN, for the 7 years prior to May 2021. Kaylin has dedicated her career to patient engagement in clinical research and has a deep passion for elevating the patient voice in research design, implementation, and development. Also joining us today on the conference and working in the background is Ed Becker, our VF media producer. Ed produces the VF Road to Wellness webinar series and the Vasculitis Visionary podcasts featuring conversations with medical specialists from around the world. He also serves as co-producer on a new podcast series, the ACR VF Guidelines, which will be launched later this summer. And we want to especially thank our sponsors, Amgen, Genentech, and GSK for their support of our 2021 Patient Virtual Conference Series. Today's session is V is for Vasculitis. Our speaker is Dr. Alicia Rodriguez-Pla, and she will cover how vasculitis may affect women differently from men, including the reproductive life cycle and hormonal impact. Dr. Rodriguez-Pla is a senior associate consultant in rheumatology at Mayo Clinic in Arizona and has a long-standing interest in the pathogenesis and epidemiology of complex rheumatic diseases, including vasculitis and scleroderma. Her previous work focused on translational research on the etiopathogenesis and epidemiology of giant cell arteritis and lupus. Her research interests are now focused on giant cell arteritis and the potential role of viruses in the disease, and most recently studying the role of microbiome in vasculitis. Dr. Rodriguez-Pla, thank you for being with us today.
Thank you. Hello, everyone. I want to start by thanking the organizers, Joyce and Callen in particular, for the opportunity of sharing the morning and this interesting conference with you today. Well, the morning, at least for me. So I would like to start by sharing my slides. So the title of my presentation is very compelling. V is for vasculitis. This is impact on women. So most of my presentation, it will focus on women. I have known this quote for a long time, but I thought that it can go very well to start my presentation today because as this quote says, a woman is like a tea bag. You don't know how strong she is until you put her in hot water. And from my point of view and from my experience working with a vasculitis patient, I have the impression that when someone is diagnosed with vasculitis, it has to feel like being put in hot water. So the vasculitis are classified depending on the size of the vessel that they predominantly affect. They basically can affect vessels of the entire body, but they have predilection for certain vessels. So they are classified in large vessel vasculitis, and the two major subtypes are Takayasu and giant cell arteritis. Then we have the medium vessel vasculitis, and the prototype is polyarteritis nodosa. And we have the small size vessel vasculitis. For my presentation, I will focus mostly on ANCA-associated vasculitis from this subgroup. I want to highlight a few general concepts about health-related quality of life in patients with vasculitis. Several studies have approached this field, and in this slide, I summarize two of them. One of them about large vessel vasculitis and quality of life, and the other about ANCA-associated vasculitis. People with GCA rank the following topics as the most important to them regarding quality of life. The fear of losing sight in both eyes permanently. They also have the fear of having intense or severe pain, feeling weak, tired, or exhausted. That is something that is very frequent in many autoimmune diseases and also in vasculitis. And also they said that there is a high psychological impact of weighing up the fear of treatment with glucocorticoids versus the fear of going blind. Many patients, they understand and they don't want to be on glucocorticoids, and they suffer their consequences and their side effects. But they are also very scared of going blind if they don't stay on that medication long enough and at the right dose. People living with Takayasu have higher levels of anxiety and depression and great physical limitations than healthy people. Another study approached the health and related quality of life in patients with ANCA-associated vasculitis, and it found that it negatively impacts patients' physical and emotional quality of life, also has a negative general impact in health and role limitations due to the physical health that is diminished. Patients, however, were not significantly different on the dimension of bodily pain. So it was more like a function, physical health and emotional quality of life. In terms of health-related quality of life, interestingly, there were no significant differences between male and female patients, at least in this study. However, the impact of vasculitis in women is significantly different from men, especially in these 4 dimensions: fertility, pregnancy, menopause, and also sexuality, although in sexuality there may be some common ground. I'm sure that you know that cyclophosphamide and corticosteroids have been the standard therapy for ANCA-associated vasculitis and also for polyarteritis nodosa or PAN for a very long time, for many years. However, I'm not sure if you know the history very well, but I just wanted to highlight a few aspects of the history of the treatment of vasculitis, especially with cyclophosphamide. So the important thing to recognize about cyclophosphamide is that it's a very toxic medication, but it's also a very good medication, and it really saves lives. The life expectancy significantly increased when cyclophosphamide was included for treatment of vasculitis. And more than 80% of the patients with GPA or MPA normally achieve remission with a combination of cyclophosphamide and corticosteroids. However, it is associated with significant toxicity and long-term side effects. There were 2 major different regimens that were used in history. Until 1996, the standard regimen was to use cyclophosphamide to induce remission with orally, with a combination with prednisone, and then use cyclophosphamide, continue cyclophosphamide, but slowly decreasing the dose every 3 months for maintenance of remission. And in general, we treated patients for 2 years. After 1996, because the toxic effects of cyclophosphamide was recognized, we switched to use other less toxic medications to maintain the remission. So we still use cyclophosphamide for induction of remission, but after 3 to 6 months, we switched to a less toxic medication, mostly azathioprine, but we could also use mycophenolate, mofetil, methotrexate, and more recently we have used like rituximab for maintenance of remission, but also for induction instead of cyclophosphamide. So just this is like the baseline about treatment and the history of treatment that is very important to understand that one of the major impacts in vasculitis in women in general is derives from the side effects of the treatment, especially cyclophosphamide. Cyclophosphamide is the major threat to women's fertility in women with vasculitis. It can produce amenorrhea or loss of menstrual periods. It is toxic to the ovaries directly, so it can produce permanent infertility or ovarian failure, and as I will explain later, also early menopause. Medications that suppress ovarian function may be used to reduce the risk. And there is, however, an increase in birth defects has not been proven, so it looks like it's not clear. But in general, we consider that cyclophosphamide is teratogenic, especially in the first trimester. Following discontinuation of cyclophosphamide, the good news is that women can conceive and have children, but we recommend to wait at least 6 months to attempt conceiving since the moment when they stop the treatment with cyclophosphamide. Egg harvesting could be possible. The problem in vasculitis is that it's difficult to do it because when we use cyclophosphamide, we normally have to use it in a situation of emergency. And it's very difficult to have the time to do the harvesting of the eggs. There are other medications that we also use in women with vasculitis, methotrexate, mycophenolate, mofetil, and thalidomide, and they can also produce damage to the fetus. So they should be avoided during conception or pregnancy. In general, we recommend to stop them and transfer to a less toxic medication that is compatible with pregnancy at least 3 months before trying conception. Certain antibiotics may interfere with contraceptives. Patients with vasculitis, they have increased risk for infection because of the immunosuppressant medications, and they may be on antibiotics. Anti-inflammatories and high-dose steroids may also reduce fertility. Intrauterine device may increase risk for infection, especially in patients on immunosuppressant medications. Sexually transmitted diseases may be more problematic in patients on immunosuppressants, and they can result in infertility. So what about pregnancy? I have to say that with improved diagnosis and increased treatment options and less toxic treatments, at least for pregnancy, there is earlier detection of vasculitis, and the patients have improved survival. That has also led to less fertility concerns. So there is a progressive increase in the number of pregnancies in patients with vasculitis. And I think it's good news because they don't need to say no to that if it's something that they really want to do. The primary vasculitis that they can affect young women are Takayasu's arteritis, polyarteritis nodosa, ANCA-Associated vasculitis, immune complex small vessel vasculitis, and Behcet's disease. Of these, most of the studies published regarding pregnancy vasculitis have referred to Takayasu's arteritis and Behcet's disease. So there are two different dimensions between vasculitis and pregnancy. On one side, vasculitis has an effect on pregnancy. On the other side, pregnancy has an effect on vasculitis. Regarding the effect of vasculitis on pregnancy, higher pregnancy loss is seen in patients with vasculitis, up to 34%. And it seems to be more frequent in patients with Behcets, Takayasu, and small vessel vasculitis. Hypertension is also at a higher rate in patients with vasculitis, especially in those with Takayasu. And up to 30% of Takayasu patients may have hypertension, and many of them preeclampsia during pregnancy. Preterm delivery has also like a higher prevalence in patients with vasculitis. Low birth weight is mildly increased in patients with vasculitis compared to the healthy population. Intrauterine growth restriction is also frequent in patients with small vessel vasculitis in particular. And cesarean deliveries are performed almost in 50% of the pregnancies. Many times they may be related to the fear of complications during delivery and wanting to avoid those complications. It looks like there is no major congenital malformation directly related to vasculitis if we don't take into consideration the medications. The maternal deaths are rare, but when they are seen, they have been mostly described in Takayasu, PAN, and ANCA-Associated vasculitis. Corticosteroids in patients with vasculitis may produce gestational diabetes. Regarding the effect of pregnancy on vasculitis, it is not recognized that vasculitis is a trigger, so pregnancy is a trigger of vasculitis. However, several cases of vasculitis have been diagnosed in pregnancy, postpartum, and also after abortion, especially cases of PAN, ANCA-associated vasculitis, and IgA vasculitis. PAN and MPA have the worst prognosis when they are diagnosed during pregnancy. The good thing is that pregnancy outcome, so if a patient has a bad pregnancy or a poor pregnancy outcome during one pregnancy, it doesn't mean it's going to happen in future pregnancies. They may have very normal pregnancies after one problematic one. The flares have been reported in 20 to 40% of pregnancies, and they are more frequent in small vessel vasculitis. Flare rates are higher in patients with active or recently diagnosed vasculitis. So it's very important, as I will mention, to have a very well-controlled disease before attempting to get pregnant. Improvement in disease activity can occur in patients with non-severe Behcets. So there are some cases with Behcets that they can actually improve during pregnancy. Regarding the treatment during pregnancy, there are several considerations: methotrexate, mycophenolate mofetil, and cyclophosphamide are teratogenic. Cyclophosphamide can be used in life-threatening situations during the second or third trimester of life. Leflunomide has detrimental effects on the fetus, and it should be stopped 24 months before pregnancy, but it can be challenging. Azathioprine, IVIG, hydroxychloroquine, colchicine, cyclosporine, and tacrolimus are fortunately compatible with pregnancy. And ideally, we need to switch the patient to one of these before they attempt to get pregnant. Oral prednisone has a low transplacental absorption, but it may increase risk for preterm deliveries, hypertension, and gestational diabetes. So we may have to use it during pregnancy, but we try to use it as at the lower dose and for the shorter time possible. Aspirin may help with preeclampsia in the general population. So we think some people advocate for the use of aspirin in patients with vasculitis, especially in those with Takayasu, that they have an increased risk for hypertension and preeclampsia during pregnancy. Regarding the biologics, there is a meta-analysis that included only one study with vasculitis patients, and they have Behcet disease. And most of the patients on this study were on anti-TNF inhibitors or rituximab. And that study found that there is no congenital abnormalities of preterm delivery. 60% increased risk of having low birth weight babies was observed, however. And there was no increased risk of serious infection in neonates during their first year. Despite that, the anti-B cell treatment could decrease the B cells in the fetus when they were born. Certolizumab has a limited placental transfer and fetal exposure, and is probably the anti-TNF medication that we favor during pregnancy. So I just want to finish this part with a few pregnancy tips. More than 1,000 pregnancies have been reported in women with vasculitis. They may possible favorable outcomes when the conception is carefully planned are possible and expected. We recommend to avoid pregnancy in patients with severe major organ dysfunction. It's ideal to have minimal disease activity at least for 6 months prior to conception. We should continue pregnancy-compatible medication when the patient has any concern for getting active disease during pregnancy. We have to take into consideration that the follow-up parameters may be different because an elevated CRP during pregnancy may be related to pregnancy and not to disease activity. It's very important to have a multidisciplinary team approach by vasculitis specialists and OB/GYN doctors, because the close monitoring is needed in high-risk pregnancy clinics. These are rare diseases, and they really need a very, very close monitoring. Follow-ups are also needed in the postpartum because up to 40% of the patients may flare in the postpartum, especially those with Behcet's disease. So now changing gears, we go to the opposite side, menopause. So there is not a lot of data in the literature about the menopause and in patients with vasculitis. One of the major studies is about the effects of cyclophosphamide in early menopause in patients with vasculitis. So as I mentioned before, cyclophosphamide affects the ovaries and produces early menopause. And this has subsequent effects of bone mineral density because there is increased risk for osteoporosis with the early menopause. There is also general and sexual well-being related to the hormonal decline. And also it has effects on the cardiovascular health because the sexual hormones are very important to maintain the sexual health. There is limited data on the effect of cyclophosphamide and the onset of early menopause in women with ANCA-Associated vasculitis. But there is one study that I would like to show to you that it was published in 2016 that studied the effect of cyclophosphamide on the onset of menopause in patients with ANCA-Associated vasculitis over the last 4 decades. So take into consideration what I mentioned at the beginning about the history of how we use cyclophosphamide. 4 decades ago, we used cyclophosphamide at a much higher dosage and for much longer time than in the more recent decades. So 94 premenopausal patients with ANCA-associated vasculitis with a mean age of 34 were included in this study. 67 received cyclophosphamide for induction remission, and 27 were treated with other medications. So these are the 94 patients, 67 cyclophosphamide, and the rest, 27, received azathioprine, mycophenolate, methotrexate, rituximab for treatment. So this graph shows the effect of these medications on early menopause. This is the age at which the medication that is not cyclophosphamide was started, and this is the age of menopause. This is the age at which low doses of cyclophosphamide was started, and this is the age of starting of menopause on these patients. And this is the same for the high doses of cyclophosphamide. As you can see, higher doses of cyclophosphamide have a significant effect on early menopause. Lower doses have also an effect, but less substantial. So is cyclophosphamide still worth for women? Does it still have a role to treat women with vasculitis? So we have to consider that the odds of early menopause is more than 2 times lower in women who receive less than 16.6 grams of cyclophosphamide than in those who receive the higher doses that we used in the past, but we don't use anymore. The introduction of maintenance therapy with azathioprine decreased the dose of cyclophosphamide and in parallel the risk of early menopause. So there is less risk with the regimens that we use now than with the ones that we used in the past. Lower risk of menopause happens also in younger women because they have a larger follicle pool. So even if some of them are affected, they still have other follicles that they can take the place. 44 years seems to be the threshold, and there is a very high risk of menopause irrespective of the dose of cyclophosphamide after 44 years. Oral contraceptives may attenuate the cyclophosphamide-induced menopause and prevent pregnancy during treatment. So we also need to consider, when possible, that we should use other less toxic medications on the gonadal function, like rituximab. However, cyclophosphamide may still be needed for some cases, and it may be life-saving for some cases. So just to summarize this last part, some of the menopause tips. Women should be counseled about the risk of early menopause, and in women older than 44 years, resumption of menses is not to be expected. Estrogen replacement therapy should be considered to help with the preservation of gonadal function. There is a need for better disease management, preferably without cyclophosphamide, but it's not always possible. And induction of remission is still vital and in life-threatening cases, so sometimes we still need to use cyclophosphamide. Regarding sexuality in rheumatic diseases, and this is the last part, sexual dysfunction can be defined as a change in any component of sexual activity which may cause frustration, pain, and decreased sexual intercourse. Higher prevalence of sexual dysfunction has been described and reported in patients with rheumatic diseases. Pain and depression are common symptoms in all rheumatic conditions and can influence sexual functioning, and actually they influence sexual functioning. Sexual functioning remains a neglected area of quality of life in patients affected by rheumatic diseases, and I have to confess that probably I'm not very good at this either, but I promise I will ask more about that starting from today. Until now, it has been more when the patients have talked to me about that, and they have had questions about when should I go back to have relationships, but I'm not very good on this area yet, but I will improve after today. A survey revealed that only 12% of patients visited by rheumatologists in routine clinical practice was screened for sexual activity, and I really believe those numbers. Vasculitis and sexuality. So vasculitis results in physical problems, including fatigue, due to both illness and medication. As we mentioned, medication have many side effects, and these can interfere with sexual activity. Furthermore, emotional or psychological problems resulting from the disease, all the fear related to that, also produce different degrees of impotence or loss of sexual desire. Mitigation of physical problems with medications, better understanding of the disease, and discussion with the healthcare team, gynecologists, OBGYN, urologists, psychologists, rheumatologists, help to identify the cause and hopefully help to manage the condition and resolve the problem. Female patients of a childbearing age taking teratogenic drugs, they may need to use contraceptives during pregnancy. And most of the studies about vasculitis and sexuality have been in Behcets. So there are several studies in Behcets that they say sexual dysfunction is quite common, almost in 50% of females compared to controls. There are several dimensions that they can be affected: diminished arousal, diminished desire, and lubrication problems. However, it was found that there is a negative correlation between depression and female sexual function. And this study didn't find any relationship between genital ulcerations and female sexual function, what is kind of surprising to me, but systematic literature also found that depression, more than the organic manifestation, seems to be very significant for for sexual dysfunction in patients with Behcets. In a study regarding neurovascular disease, found that male sexuality actually was more affected than female on these patients. And just to finish, I would like to present this paper that is not related with vasculitis, but I find very interesting because it talks about the vascular impairment and the sexual dysfunction in cardiovascular diseases in general. like atherosclerosis, hypertension, diabetes, and obesity. And they say that they are linked with male and female sexual dysfunction. And what they claim in this paper is that the vascular health plays an important role in sexual function. And we already know that from patients with atherosclerosis. So there are many initiating factors, age, physical activity, that results in events like atherosclerosis, inflammation, and this ends up in a final common pathway of increased vasoconstriction, decreased vasodilation, and remodeling, and this produces sexual dysfunction. So this paper that is not related with vasculitis claims that there is an important role of the immune system, even in patients with atherosclerosis, in the development of sexual dysfunction. And they claim that maybe targeting the immune system could be a valuable target to improve sexual dysfunction. And this is basically what we are doing in patients with vasculitis. So maybe we are helping with the vascular dysfunction by treating the inflammation with immunosuppressant drugs. So just to summarize my take-home messages, cyclophosphamide is a major threat to women's fertility and pregnancy, and is associated with early menopause. When pregnancy is carefully planned, favorable outcomes are possible and expected. A multidisciplinary team approach by vasculitis specialists and specialized OB/GYN doctors with close monitoring in high-risk pregnancy clinics is needed. Vasculitis results in physical challenges due to both the disease and therapy, and emotional issues can interfere with sexual activity, and they should be treated. Mitigation of the physical problems, psychological problems, and a better understanding of the disease and treatment with a multidisciplinary specialized team may identify the cause of the sexual dysfunction. Many times it can be multifactorial and guide, hopefully, the successful treatment. These are my references, and I just want to thank the Vasculitis Foundation again and all of you for listening to my presentation today. And if you have any questions, I hope we have a few minutes for those.
We sure do.
Alicia, thank you so much, Dr. Rodriguez. Okay, so we do have some questions that were submitted through the chat window, and then we also have one person who raised their hand. So let me start with the questions in the chat window, and then and if we don't get them answered in this session, we will ask some of the other speakers to address it. So there was a question about, I have the marker for ANCA. My numbers don't spike. As a result, I no longer have monthly bloods taken. Should I be concerned about not being monitored anymore? Can it be dormant and then come back? Can there be damage inside with no symptoms? And is hair thinning a loss of symptom?
So I'm assuming that she was diagnosed with vasculitis in the past. It sounds like that. So I normally monitor the patients for forever, almost like at the beginning when I think they go into remission and they complete the treatment. I tell them, I even want to see you more frequently than when you were on treatment because I'm worried about relapses. After 1 year, the risk of having a relapse decreases, and I discuss with the patient if we should space out the monitoring. But for at least 2-3 years, I still like to do blood work and urine analysis regularly and check the ANCA in everyone with vasculitis. The ANCA positivity doesn't always mean that the vasculitis is active and doesn't always mean it's going to come back. So if it has been in remission for many years and it was properly treated, in most of the cases, it will not come back. It's a matter of discussing with your doctor, I think. If you are still worried, I think it's fair to say, can we just have one appointment every year and leave it open in between? And if I have any symptoms, can I call you back and get tested and come back? This is an approach that I normally have with many of my patients, and it seems to be well for them. But I think if it has been many years, even if they are positive, many times it is in remission. We have not been able to correlate ANCA positivity with disease activity or with relapses.
Okay, great. Another question we received is, I am trying to exercise more often, but I can't stand the feeling of becoming hot and overheated. Is this common with our disease, GPA? Is the discomfort physical, mental, or both? And is there a way I can address this so I can stop avoiding exercise and start embracing it?
I mean, that question about if it's physical, mentally, or both, I truly believe in the mind-body connection. I really think that it's very difficult to differentiate between them. I mean, everything that happens to you physically, if you don't feel okay, it's going to affect your emotional well-being. And if you are worried about vasculitis, everything is going to look like worse, and you are going to have more fatigue, more weakness just because of the worry. So it can be both. It can be frequent. Patients with vasculitis have fatigue and it's more difficult for them to exercise. What I normally recommend is to learn your limits. I mean, you don't have to run a marathon. I think it's, for many patients, it's not going to be realistic to try to go back to total function and to be as they used to be. Some of them, they get it. And I have had patients in the military that I think they have to be in an ad on TV, in a commercial, because I cannot believe what they are able to do with treatment. But I think the most important thing is probably there are a component that is physical, like you are probably more fatigued, that makes you to be like to get more heat, to feel more heat. And there is a component of that you don't want to get very tired because you know that you may have a flare too. Stress produces flare. So I think it's a component of both, and knowing your limits and trying to limit the activity to the point that you don't get very completely exhausted, but you do some kind of activity is a good starting point.
Great, thank you. There was another question. Kaylin, can you let Jody, I've lost my screen real quick. Sorry, just trying to get back. Kaylin, can you let Jody ask her question?
Yes, so Jody, you should be unmuted now and able to ask your question.
Hi. Yes, I was, a couple years ago, I was diagnosed with Lynch's sclerosis. And I'm just wondering if that's part of the EGPA. I also went through menopause kind of early. I had where they burned the lining of the inner lining. And both of those things happened when I had been diagnosed with EGPA, but I never put together with the vulva disappearing and stuff, is this a normal reaction to EGPA?
The diagnosis was lichen sclerosis.
Yeah.
So many of these are also, like the lichens affecting the mucosa are normally autoimmune diseases. So they are associated with any other autoimmune diseases. We see them more frequently in vasculitis and other autoimmune diseases. I don't think there is a specific link with EGPA, but just in general, like autoimmune thyroiditis, like thyroid problems with autoimmunity, many of these autoimmune diseases just affect the same patients. So they may be potentially related in that sense.
Okay.
And then what was the other question?
Well, what kind of treatment would you do for I'm just putting creams on it. Is that the normal thing?
That's the normal thing. I normally refer the patients to the OBGYN or to the gynecologist. Sometimes the dermatologists are also very knowledgeable on that.
Okay.
So if you haven't been seen by a dermatologist, I recommend you to do that. But they mostly use creams. That's what I have seen in my patients.
Okay. All right. Thank you.
Thank you.
Great. We have another question from Anna. I am 70 years old, diagnosed with urticarial vasculitis. I have had no flares while on an IgE blocker for 1.5 years. Do you know long-term effects of the biologic? And it's the OMalizumab. And Alicia, I apologize. I am famous for not being able to pronounce that drug's name correctly.
That's good. Omalizumab. Yeah, I mean, we don't know. I mean, that was one of the things that when I even review the literature now, I realized we don't have so much information about biologics yet. This is a relatively new medication. Even for rituximab, that we have been using it for more than a decade, we still have a lot of questions about long-term effects. Like we know more about cyclophosphamide than about these new medications. We think they are safe. In general, we consider all of these are safe, but we also have the question about how long do we need to treat? It's going to be like with the typical one that it was 2 years of treatment to get remission, or now we are getting more into the chronic aspect of the disease because we don't use so much toxic medication. I think we don't have the answer for that yet. In general, we consider them safe and we consider that they may be used for many years without major side effects. So I may have autoimmune urticaria. That was okay.
That was awesome.
So many times, the autoimmune urticaria, if it's related to the urticarial vasculitis, it may be treated with the same medication. If they don't respond, I recommend you to talk to a dermatologist because they may have tips for maybe using antihistaminics that they may help with the part that is more urticarial. So that would be my recommendation for that part. Like, I think if you are not improving with the treatment that you are using for urticarial vasculitis, I think you should see a skin doctor for other recommendations about treatment. But it sounds like sometimes they use antihistaminics in combination with the other medications.
Alicia, we had another question come in through the chat box. I have only a minor form of Behcets. I get oral and genital ulcers. I've had some joint pain in the past, but not for years. Is pregnancy a concern for people with only minor symptoms of Behcets?
It shouldn't be a concern. Actually, some of the studies said that Behcets can improve during pregnancy. So it may even be good. We see that in patients with rheumatoid arthritis. Normally, rheumatoid arthritis gets better during pregnancy. If it's minor, I will not be very concerned. And if you are treated with colchicine, that can be continued during the pregnancy too. So you may have no problem. That's what I would probably expect. You will need to be followed to make sure that's the case, but I don't think, I will not be afraid of expecting many complications if it's just a mild form.
Thank you. There's another question. My 30-year-old daughter has had active disease for almost 2 years. They have not pinned down what type of vasculitis, but have treated her with methotrexate, Cellcept, and azathioprine without finding remission. How long is it safe for her to keep trying these, and what else could be done?
I'm assuming that he has had all kind of biopsies, if he has any skin lesions or kidney biopsy. Safe to use these medications. It depends, for example, if she wants to be pregnant, if she wants to become pregnant, she will have to stop methotrexate and Cellcept before pregnancy, 3 months at least before conception. Azathioprine can be continued during pregnancy. These medications have been used for very many years without major side effects. So potentially they could be used, but the worrisome part is like without finding remission, because if it's not on remission and they don't know what kind of vasculitis it is, I think it makes more sense to try other treatments. Unfortunately, sometimes we don't have a magic wand, and the only way to know if a medication is going to help is by trying them. But if she has tried these, depending on the type that it looks more, she has, like, if it's more Takayasu, maybe anti-TNF therapy can be tried. If it looks more like ANCA-Vasculitis, maybe they can try rituximab. So there are other options that they can try instead of continuing in the same medication if she's not getting anything from them, not getting remission. I think it will make more sense to try something else.
Right. Another question that came in via email was, weight loss is a symptom of ANCA-Vasculitis that has greatly affected me. My appetite isn't what it used to be, but I never skip a meal. I try eating every 2 hours. I've tried 3 square meals, with the heaviest being at noon. I've been eating a lot of mashed potatoes and rich desserts, still having trouble gaining weight. Are there any suggestions on how to gain weight?
I will recommend even prednisone. Well, we don't know, but I wonder if prednisone. But if she doesn't have activity, I think the best recommendation will be to talk to a dietitian. There are some medications that they can use to increase the appetite if she needs them. So that will be my recommendation, to try to talk to a dietitian, because we don't recommend prednisone if she doesn't have any disease activity, only to increase the weight. So it will be talk to a dietitian for medications.
Okay. And we'll make this the last question. So this question, I got urticarial vasculitis after the huge fire in Nern, California. Have you heard of any etiology from toxins?
I got you vasculitis at a huge fire from toxic. Well, I mean, toxins have been suspected in vasculitis. Infection has been suspected as a trigger of vasculitis. None of them, as far as I know, has been proven, but I mean, toxins have been under consideration for vasculitis, yes, but I don't know of any in particular that comes to my mind, and any of them has been able to be proven.
Okay, great. Kaylin, do you have any follow-up, any final questions or comments?
Yes, I think Trish Donahue has a question.
Oh, okay.
I'll let her. Okay, Trish, you should be able to ask your question.
Yes, I know you're not talking about cryo, but I have cryoglobulinemia vasculitis, and I'm concerned about the effects of small cell vasculitis. What are they? And how do I know when they're worse?
The cryoglobulinemic vasculitis?
Yes.
It's like a kind of antibody that deposits and it produces inflammation in the vessels. And it may be associated with hepatitis C. So one of the most important things is to see if you have hepatitis C infection, because if you do not. Have you been treated with rituximab?
I've been treated with rituximab for 12 years.
For years. So many times it goes into remission. You just have, what we normally do is we follow the patient once a remission is achieved, and with blood work and urine analysis every 3 months to make sure your kidneys are not involved. We ask for any skin rashes or any neuropathy that can be seen with cryoglobulinemic vasculitis. And if there is no signs of relapses, you don't need to be retreated.
Thank you.
Dr. Rodriguez-Pla, thank you for your wonderful presentation. It is such an important topic to our patients. We also encourage everyone to watch the other 4 recorded sessions from today's conference. And we want to especially thank our sponsors, Amgen, Genentech, and GSK, for their support of our 2021 Patient Virtual Conference Series. Thank you again for joining us today.